That should be working good, eh?
Yeah, it's perfect. You guys are welcome to start whenever you're ready. Just hit go live on YouTube cam when you're ready to go.
We've actually cracked on with go live already. These guys want to see how we do the podcast. Okay, so Baris, before we kick off,
Yes.
Are you going to be presenting like a PowerPoint presentation as well?
All right.
Okay, so I want you to practice to get that PowerPoint to go. So if you see in the bottom it says screen, just to the, yeah, if you press that screen, click on the screen.
Wait. Yes.
Then you can share, and that will then bring up a window.
Wait a second.
Okay, so Damien, once we've got this off, are you going to jump off, or it's not recording you, it's just recording Baris and myself, eh?
Yeah, I'll bounce.
Okay, awesome. Just want to make sure that we can get that thing. And the nice thing about this is that everything's recorded, and then Damien and his team will do some editing. So I don't know, if your telephone rings or something happens, we can just take it out and we can start again. And for those who are watching on YouTube, I see we've got 18 people who are actually watching the podcast. Welcome. It's great to have you guys. If you have any questions, please type them on the comments, and I can ask Baris those questions when they come up. Yeah, it's so nice to have actually see what you see us recording the podcast, because this podcast has gone out to like 70 countries around the world, more than 15,000 people, but now people can actually see what we're doing in these podcasts. Oh, there we go. That's looking good. Okay, that's fine.
No,
so
it's
now
okay.
Just enlarge that. Perfect. That's perfect. Damien, you happy with what you're seeing there?
Cameron.
Spot on. I'm going to bounce.
Okay.
Can I try the other one? The computer's microphone.
Yep,
Is it better? What do you think? Is it better?
It sounds to me a little bit clearer, actually.
Or this is better?
Okay, testing, 1, 2, 3.
Hello?
Yes,
which is better?
Clearly. That one. So Baris, what is nice is it records your audio on your side, it will record my audio on my side. So as long as you can hear clearly, I'm quite happy with what's happening.
All right. Oh, that's so bad. I can't talk with noise canceling. Is so bad. I'm ready.
Oh, there we go. The comments are coming in. They're better with a second sound. They're very happy.
This one is better. I hope.
Fantastic.
All right.
Okay, perfect. So what I'm going to ask Baris is if you can stop your share. And what we'll do is I'm first going to do a little introduction. I'm going to chat to you and ask some questions. And then when we get to the point, then you'll share the topic. Okay. You happy?
Yeah. Give me 10
seconds.
10 seconds to take
your
it
time.
off. Yeah. So, Cameron, how are you?
I'm very good, man.
Your broadcast. That's very nice. You create a fashion. I like it, and I'm watching after your broadcast. That's good. It's recorded, and it's. I appreciate to be part of it. Thank you very much for inviting me.
No, that's a pleasure, Baris. It's absolutely a pleasure. So what I'm going to do is if you see me on my telephone, it's not because I'm playing around, okay? I'm actually concentrating to catch some sound bites for the podcast. Your video has gone off completely.
All right.
Tell me when I can't see that video at the moment.
Talking with me? No.
But I can't see the video. I don't know why. I can hear the sound, but I can't see your face anymore. Yes. Okay, so what you can do is you can close this window and re-log in, and then hopefully your video will pick up. So for the listener, I see we got 26 people viewing. Guys, please just be patient with us. These are small little technical problems we're trying to iron out.
So I'm closing everything, right?
So you can log off, close the window, and open. Oh, there we go. I can see you. I can see you. Perfect.
All right.
Okay. So we've got 1 hour, and you're happy for me to start off now?
I'm ready.
Okay. So let's go. 3, 2, 1, and we're live. Ladies and gentlemen, welcome to another episode of the Rhinoplasty podcast with me, Dr. Cameron McIntosh. For the month of August, we've got a fantastic lineup all around preservation rhinoplasty, and this is brought to us by this really cool company from France called Comeg, and they literally concentrate very well on a special piezo machine. Now, if you are interested in wanting to get a cool discount on this machine, you're going to have to listen right to the end of the podcast, and then I'm going to give you the details of who you need to email to get a 10% discount. Okay, so thanks to Comeg for bringing this to us. So tonight, I've been burning for tonight's show. This is a man I've tried to get to South Africa numerous times. I tried to get over to Istanbul, and because of COVID, it couldn't happen. We've had the pleasure of interviewing Baris once last year. He blew everyone out the water. We had more than 1,000 people online listening to him. So it is such an honor and a privilege. Baris, thank you very much for taking your Monday evening to be with us and to our listeners from all around the world.
Yes, it's very good to see you. How are you?
No, Baris, I'm good. We had a very cool day today. We actually opened our new surgery center. So this is like the cherry on the top of the cake for me to be able to chat to you tonight all about preservation rhinoplasty.
So I saw on your Instagram, your new clinic. It's amazing. It looks a small hospital. So I want to be there. I want to visit you. I hope all that COVID issue gonna finish and come back.
No, we're going to get you here. We've set it up. So what I'm quite excited about it, because I've been so lucky to visit so many people all around the world. I've tried to take all the good parts and put it together. So in the clinic, we've got a cone beam CT scan machine. We've got 2D photos. We've got 3D photos. But downstairs in theater, it's also set up with 5 permanent video cameras to film all the different aspects of rhinoplasty. And then that goes upstairs to our production room so that really we can do cool videos of surgery. So we actually next month going to be filming Olivia and Miguel. They're both coming out to our Congress, and they're each going to do a live surgery. So we're quite excited about that. So Baris,
I changed my internet. Can you hear me? Because your video stopped. Sorry. Is it better?
That's better. That's better.
All
okay.
right.
Listen, don't worry about these technical things. The guys will remove them for us. So my first question to you. So
right.
we know you as this incredible rhinoplasty surgeon that you're giving so much back to so many people and teaching them. But take us back. How did you become a doctor, and how did your interest in rhinoplasty start?
Oh, it's a very interesting interview. All right. We are starting from the high school. So I'm basically, how can I start? All right. The point is, my parents think I'm not very good about the theoric education. So they send me to a job school. In Turkey, we say job school. So it's not a high school for preparing the college. It's they teach high school also. The other half day, they teach you a job. So I became an electronic technician first of all. So in that high school, you educate for the hand skills. we carve metal. We work on the electricity of a small house, something, and we was doing the walls. So I realized that to be an electric technician is not a good, doesn't have a good future. So my parents me to be a doctor, but I want to be an engineer. I choose my last choice. In a list, everything was, the last one was the medical school. So I to be a doctor. So the years I always thinking about the left medical school and going to be engineer education. So after 3 years, there's no go back. So there's no return. So
Yeah.
can I be? So to be a surgeon, I difference because I'm very bad about the memory. I'm the left-handed.
Yes.
I only trust my hand. That's all. So in the medical school, I had a rhinoplasty. Okay, that's change. So first I go to the ENT and then go to the plastic surgery. So I had a rhinoplasty. I had a revision because of the deviation. So it's very plastic surgery, rhinoplasty. I was a rhinoplasty patient. So it was very interesting experience for me. And what I was want, I want to be an orthopedic surgeon because I'm so interested in the microsurgery. The plastic surgery, but with the rhinoplasty, so I went for the consultation again. They call me and they want at first month, second month, the rhinoplasty check. I realized what she is doing there. So in my city, they only focus on the burn surgery. I choose Istanbul surgeon. So 5 years I did only hand surgery, microsurgery. The rep is the very interesting. You suture the 12 millimeter vessels at the tip of the fingers. So it's increased my hand skill. Difference there. So story of to be a the doctor and a plastic surgery resident. So why the rhinoplasty? The next question. So the rhinoplasty, I watched rhinoplasty a lot in my residency. I want to be a rhinoplasty surgeon. In the plastic surgery, I couldn't find any space in the hand surgery centers. Send me a small city. So I left, quit from the government service. So in the private practice, the rhinoplasty is the key in Turkey. Okay, if you can do good rhinoplasty, you can open an office. So I start like this. So I realized the rhinoplasty, you need high hand skills. You have to give 100 decisions in the surgery. And after the plastic surgery residence, I realized really at the end, so yes, it's like a chess playing. You like who says Jack Shear's friends?
Yes.
Constantine. Yeah, Mark Constantine says it's a chess play. So I realized I need an art education. So I go to the art school. And I said, I'm a plastic surgeon. Teach me something, sculpture, drawing, and it changed a lot. So I teach my artists for years. So maybe I some small difference in the rhinoplasty because of the art education.
Yeah,
that's the story.
Wow, man. That's fascinating, eh? Sure. And so do you only do rhinoplasty, or do you do any other facial plastic surgery or plastic things?
On the rhinoplasty.
Wow.
Because I want to create a difference. Even if you do 5-10 things, you can't concentrate. Even one thing, or for example, the point is rhinoplasty. So learning rhinoplasty never finish. So rhinoplasty, one surgery is enough. You can't finish it. You want to be good only one thing. So it's the key was to be concentrate. If I feel not confident in for example, breast surgery, I was doing good augmentation, but I'm not good about the reductions. So I left it. So facelift, symmetry, I left it. So rhinoplasty now it's thousands. So I focus on the one thing.
So Baris, that's interesting for me. Now, speaking to a guy like Prof. Dean, he was saying, we had a very interesting chat. Out there's people who put themselves out to say, oh, I do like 500 rhinoplasties a year or 600 rhinoplasties a year. Now, as a person where you at, I know you mostly endonasal approach. What's the capacity of the amount of surgeries you actually do in a year normally?
I look at the statistics. So I did 3,050 or 400 in a year, but it was so much. So you feel neck pain. So I reduced the job. So we plan how much rhinoplasty to do. So I want to stay in 200 or 250. So my order to my secretary, 20 or 30 rhinoplasty in a month, not more. So
that's great.
1 or 2 rhinoplasty.
Wow.
Yeah.
Wow. Okay. So before we get more into rhinoplasty, let's just take a slight turn here.
All right.
What do you do when you're not doing rhinoplasty? What are some of your other interests?
Now, if I left rhinoplasty?
No. If you're not busy, what other interests do you have apart from the sculpture and the drawings and rhinoplasty? What are you doing when you have a day off, for example?
In the office, I left filler everything. I was saying I'm on the surgery and the rhinoplasty. But in the COVID time, because of the lockdown of the operating rooms, I turned back, but not too much. Is if I'm not busy, I do one Botox or one filler. But even I don't want to do anything more than rhinoplasty. Nothing on the nose. Sometimes lip filler. That's all. It's enough to talk with the patients, consultations, prepare lectures, and focusing on the your patients' follow up. So that's too much.
No, it's a lot. So Baris, before we get into the topic, the last question I had. Now we have listeners from all over the world. We have like 70 different countries.
Really?
Yeah, it's great. And what would your advice be for the younger, possibly medical students or residents who are listening to this and they're interested in wanting to get into rhinoplasty? What are some of the tips you'd like to share with them?
Okay. To increase your hand skills is important. And we start to write surgery 24, 25. But even you do something in your house, fixing some machines, okay, doing your electricity stuff. I did a lot. It's improve your hand skills. And to be a good or facial plastic surgeon, also you need eyes. If you are doing aesthetics, also you need to improve your beauty. So you can take that education in the art schools. It's changed my life a lot because I give several times art class in Rio, in Bern, to the plastic surgeons. I was bringing, it's limited to the 30 people. I teach how to draw noses. I bring clay with the without nose, and I give the mask to people, and I said, make nose to fit in that face. And in 5 minutes, you can see the difference. Who took education? Jack Sheen is amazing sculpture. So if somebody doesn't take an education, you see the nose is very big or very small, even doesn't fit the face. So that education is so important. I say to this home message to all my visitors: find the art close to you. And I work here every Saturday. My last consultation was my art teacher. I finished my job. We take one. We draw nose for 1 year.
Wow.
That polygon concept is very basic drawing things. So
yes,
prepare with my art teachers, John and Yusuf.
That's fantastic. Yeah, that's great. Well, Baris, I think there are quite a few guys sitting online here wanting to listen to the talk.
Right.
Do you want to share the screen now? And
Yes.
and then you're going to fire away. And what I'll do is I might interrupt you with a few questions as we go. And then if people ask questions on YouTube as well, I'll ask you.
So you will stop me? That's nice, and we can discuss it. Yeah,
definitely. Yeah,
problem. I like that. Wait.
And then what I'd remind you is, whilst you are doing the presentation, because not everybody will watch this on YouTube when we do the final release. A lot of people are listening on the podcasts in their motor cars or on the train or whatever. So when you are explaining, try and imagine as if somebody can't necessarily see your slides.
Okay. So I'm sharing my screen. Is it okay?
That looks good. Now, yeah.
So face also. So I see all my.
That's fine. That's fine.
That's better.
That's perfect.
I want to see your face. Okay. You happy with this?
It's looks great.
These are my disclosure. There's a book from and we have a Congress book, Preservation Rhinoplasty. I have royalties, I have to say this. So the Preservation Rhinoplasty book published. So that's very good. So I really appreciate
How can people get hold of that Preservation Rhinoplasty book?
I think people can go to the preservationrhinoplasty.com. There's a link to this book, so people can buy online, and the staffs are sending the book with ship with UPS. And I have we design an elevator with Daniel elevator. People love that for subperichondrial dissection. I think it's okay. So Rhinoplasty start. We decided to make a meeting in Istanbul, I think 4 or 5 years ago. So I couldn't find a good name. It was, I don't want to say, very bad. And we decided another one. And this article published, Preservation Rhinoplasty and New Rhinoplasty Revolution. So when I saw it in a minute, I sent the email to Rollin. So that's amazing for the upcoming meeting, Preservation Rhinoplasty meeting. So we details about this article. So the team, Rollin Daniel answered me in a day. Yes, you can use Preservation Rhinoplasty name for a meeting, but only one condition: if we write a book. So when we are preparing to the meeting, we finished this book in 6 months. That year was so busy for me. My family couldn't see my face. We worked a lot, and we finished the book, and the book press finish just 1 day before the meeting. So that's the famous meeting, 700 people. Some people count 600, 700, 800. I don't know exactly the number. A lot of people came, very afraid to see a lot of people here. And we repeated in Rome. And I talked with the interim in Russia. Yeah, we have to come together because like two concept is fighting. I don't want to fight because that's very normal. You promote it. Yeah, we have to do that to reach the people. It looks like structure, but it's not. So the interim accepted our. I said, please be the president with Daniel and everything. So we come together. So our logo is yin yang. I will explain what is it. Surgery in structure preservation meeting. The interim did life surgery. I did preservation rhinoplasty. So that's the case in the meeting. Another preservation rhinoplasty result, axis deviation. Heights, I will talk about. Dorsum on the side. So, the interim, at least 80% of the cases, we can figure out preservation concept in Europe. But I did in Brazil, they have totally different indication. So structure is South America. So because of immigration, structure preservation, both is really important in US. But if we do structure to everyone, in my country it's overkill, healing surgery. So because of they need reduction and they want definition. So I don't want to put a lot of graft. So structure now our message to people is like yin yang. Now about the combination. So we don't do only preservation to everywhere. So we can preservation for soft tissue. You can do structure for tip. You can do dorsal preservation for the dorsum. That's the team. Roland Daniel is our director.
Now we can see how far we are from
is
the
our teacher.
to the
I'm responsible
entrance
about
point.
tip surgery, and Peter Palazzi is responsible about anatomy. Now, my brother Aaron is doing a surgery on the cadaver. What is preservation rhinoplasty? The summary of the preservation rhinoplasty article is that if you have a beautiful dorsum, preserve it. You can use let down, you can use push down. Many people think about preservation rhinoplasty is only dorsal preservation. No, it's not. And also there is not only one dorsal preservation. There's cartilage preservation, there's osteocartilage preservation. In the septum, you have low septal strip, you have high septal, tetris, you have middle septal strips. Preservation is the soft tissue preservation. If you have thin skin, so scar contracture is your enemy. So subperichondrial dissection is very good tool for that because in subperichondrial plane, only chondroblast. So perichondrium get thicker, cartilage get little thinner, but you don't, because of you don't touch soft tissue, fibromuscular, so you don't touch fibroblasts, and there is no fibrosis in subperichondrial plane. With subperichondrial dissection, you can preserve the ligaments more. Even subsumous dissection, you can preserve the ligaments a little bit. So the ligament preservation is really important for reduction. So you can, because in augmentation, no problem. You put the cartilage and the skin envelope follows the skeleton. But in reduction, if you do reduction to the skeleton, skin doesn't listen in a area. So the ligaments is really nice tool to control bed rate in supratip and the lateral supratip area. So maximum cartilage preservation, especially is very important for lateral crural. In this point, our home message is to over resection at the cephalic part of the lateral crura, because we create the pinch nose is iatrogenic, alar notch is iatrogenic because of the over cephalic resection. And if it's possible, do it close to preserve the columnar system. So, can we stop? We can talk. Can you hear me?
No, carry on. That's good, because the first thing I'm considering now is we see a lot of people who've done so much cephalic resection. How then do you, in revision rhinoplasty, bring preservation rhinoplasty in?
Yeah, in secondary rhinoplasty preservation, no, this is basically in primary concept. Preservation also in the article Roland said to decrease, also make the revisions easy, because if the surgeon removed the half of the and left really small pieces, so if you create a big space, that space between the upper crura, if the pathology occurs like pinch nose, huge alar retraction, it's very difficult to treat that. So to preserve the natural anatomy as possible as, decrease the deformities. That's the point of the preservation. In secondary, structural rhinoplasty is the gold standard, and in augmentation for the Latin noses, at least for the tip, it's structural rhinoplasty is the gold standard. It's a book. We have a book, page about the preservation. So I want to talk about more on my responsibilities. I responsible about the tip surgery and the ligament preservation. I focused on the ligaments 2006. So I was thinking about hand surgeon, everything. You know, in hands, you had a hand crash and patient came to the emergency service. You mark everything. Where's the nerve? Where's the tendons? Where's the superficial tendons? And you elevate the skin flaps. First, you mark before you plant the finger. So you mark everything. I did rhinoplasty as I learned. I realized it was changing after healing. So the deformity settling on the bone area, and I said, "What's happening? Nose is changing a lot," and I seeing the surgery is totally different. Well, I 15 years ago, I said, even we on the rhinoplasty, by the way, Cameron, I started to rhinoplasty with the open approach. Years only open surgery, no close. So I was, and I said, even no rhinoplasty, you perform nothing. Don't touch the bone, don't touch the cartilage. Elevate the flap, and I think that nose will not be the same. That was my point. So what I did, I marked everything. Probably I am cutting something. In the abdominoplasty, you have to repair the fascia. So in the hand surgery, also you close the and you have to fix everything. And I realized I'm cutting tissue. I don't know the name on the supratip mark, and I said I found a new thing, new term, something, a new tissue, but it's. And I realized 1960, Ivo Pitangi already described that. So and we refer that article, and in that with Roland Daniel, he saw what he helped a lot to publish this article, subperichondrial, subperiosteal dissection, and with the ligament. Management of the nasal ligament. That's my first article about the nose. So it's people start hear my name and with the Roland. So God to meet with Rolly. He's my godfather, helped me a lot. So let's go on. So still, a lot of people doesn't understand what's the function of that. Okay, there's a ligament for sure. A lot of resecting it, or like Gyron removing and suturing the dermis to the anterior septal angle, and some people prepare suturing to the anterior septal angle or making a flat medial crural. So let me show this simple animation so people will understand. We know the tip cartilage forward, sometimes 10, 12 more than the anterior septal angle. How is possible? That's the answer. Because the ligaments and not attaching to the tip dome, it's attaching to the medial crural, not middle crural. The columella breakpoint and the foot place carrying the tip cartilage, pulling forward, and the pitang is taking a power from the SMAS and controlling the supratip. If that's happened to me, so I dissect, I cut the ligament, so that tissue I didn't resect, and come to the supratip and create a supratip bulge. And, you know, there is a natural distance between the anterior septal angle and the domes. You got the pitangi to reach anterior septal angle. You remember, open the flap, and to find the anterior septal angle, you go through sometimes. That's the pitangi ligament. Yes. So dome cartilage collapse to that empty space. So you need cartilage grafts. So because of this, open rhinoplasty needs more cartilage grafts. When I start to repair that ligament back to the, suddenly my rhinoplasty changed a lot. I strut, that's all. So still spent years to control it, but cut it. So it's like next level.
Yes.
Yeah. That's my supratip deformity. I'm trying to understand what's happened, why I had a lot of supratip deformity. And I have to say, I listened to the Intorimi's rhinoplasty story. In this point, he to the also he's doing more augmentation rhinoplasty work. I'm working on Asian now. In this point, I turned to the ligament preservation. Okay, many or all of the surgeons had. So I figured out with the ligaments. See, think about the muscle. This is wrong. My 3D made a mistake. It's Yves Saban's amazing anatomy works. Pitangi ligament is a thickening of the transversalis muscle, nasal muscle. Evo Pitangi is coming from the dermis. No, it's exactly starting from the SMAS. There's two arms. There's two scroll start Pitangi ligament. When you cut it, tip collapse. And when the transversalis muscle starts, it's the most powerful muscle of the nose. So the patient are sleeping and when they start smiling, the mimic of the nose. The muscle is the midline. Collects the soft tissue to the midline. I think that's the muscle bulging. That's that space. Bleeding, fibrosis, but also there is a soft tissue. We see that. It's muscle bulging. With the ligament, problem is over definition, not supratip. I really inject to the supratip, straight supratip, really rare. Pitangi ligament decrease a lot. So in my country, most of the cases are thin skin, strong cartilage. So subsumous dissection, we know the nose heals forever. All life. So the in this plane there's no fibroblasts. Activate chondroblast. This is under the chondrogenic section. Maybe if we do clean subsumous dissection, maybe we can be under the fibrous perichondrium. This is exactly perichondrium. The crural ligament, pitanga ligament, and scroll to scroll sesamoid. This is pitanga. You see nasal smas coming here and join to the medial crura. It is not easy at the beginning. It is possible to do tip surgery with preserving the pitanga ligament. That creates a domes and also take a power from the supratip and pulls the medial crura upward. If you preserve it, there is no space to put septal extension graft. But for augmentation, you have to cut it, even if, especially supratip augmentation, you have to cut it. Otherwise, you can't augment. But if you preserve, you do reduction, but your supratip point comes with your reduction. That's the point. You do deprojection. You see, if I release the maxillary spine, foot place comes back close to the maxillary bone, but because of that connection, you pull the supratip. That's really very good power. You control that. It's sometimes thicker than flexor carpi radialis. Really thick anatomy. Lots of vessels, lymphatics pass through. Even I want to control this. I suture the upper lateral perichondrial again. So it can control the intermediate wall. We control the apex with grafts or preserving the dorsal cartilage. We control the base wall, but the middle wall control with the transversalis. Yves Saban says transversalis muscles can open the internal wall and close the internal wall with the constrict ring effect. Okay. I said to many patients, contract your nose muscle. I see when I look into the nose, please do that. Many patients, internal walls is opening, really. So the muscles are really important for internal wall. That transversalis muscle making an insertio to the upper lateral caudally. And with Charles saying it's stabilizing internal wall because it's a yes, there's a connection about transversalis muscles making a ring and coming to the nose base. So this space really controls the transversal and it covers the nose again. So even you can make white dissection and you can do red section with this. So look what's happening. This is big. So you see that dimple is because of the pitanga. You can't put tapes for months. Huge nose, big reduction. You see the supratip connected. Imagine there is a string from the supratip to the medial crura, and you can put your tip. Yeah, that's natural anatomy. The mistake I have to say, people cannot do the same mistake. I think if the nose is bulbous like this, round, pitanga should be long. So I have to shorten. I resected a little bit muscle and suture back, or I did plication, but I achieved because of the shortening. So I achieved because the pitanga shortened, so drop one side of the anterior septal angle. So I think the pitanga ligament is in good length for many. At least half of them it is short, not long. So plication doesn't work. Don't plicate. Preserve or dissect. I will show when to dissect. You see, very heavy nose. You think about there's a string here. I control the super Pitanga ligament. I put, I don't remember, maybe only with the lateral porosity, but maybe there's a tip grafting here. But Pitanga effect is amazing to control here. So definition, my secret about the definition, even in close approach, is the ligaments. Stop here to talk a little bit. I can go details. Are you here?
No.
Hello. Maybe it's close. I'm checking your voice.
So no, I'm thinking, what the hell am I doing this open approach and cutting through the Pitanga ligament the whole time? Now, it kind of makes me a little bit emotional, thinking, oh dear, now what? Because my training has been open approach for the last 7 years. It's just open approach. So I think understanding this of trying to preserve this ligament at the same time is just, it's like a complete shift in my mind of a different way of doing rhinoplasty.
Okay. So I like Aaron says, in structural rhinoplasty, you push the cartilage to the skin. In ligament preservation, you pull the skin towards the cartilage.
Yes.
That's explaining. People like that saying. So you need these instruments to do subperichondrial dissection. Another home message: if you live in South America, I think the best dissection is subperichondrial on the dorsum, but subsumous on the tip. Because you want more red rape on the tip, because subperichondrial dissection, red rape is limited, so you need white dissection if you need. So if what I do, I pinch the tip skin. If it is loose, so I want more red rape, I do clean subsumous dissection, as Carlos said. But how I have to preserve the crural ligaments, I do subperichondrial dissection on the dorsum. So I basically suture the perichondrium back to the dorsum again, to the upper lateral. Okay, you need these instruments to do close. Crural retractor, tiny hooks, and the Nazem Cherkesh scissors. I like this, very pointed. And Daniel Chakra elevator we designed for perichondrium dissection. It's like dentist elevator, very tiny. And we have key points step by step. I want to show. 1 is posterior septal angle. 2 is W point. 3 turning point. 4 corner of the bone, medial cleft. And the 5th is opening a window between the Pitanga. We always follow this step. So I start transfixion incision 5 millimeter higher than the caudal septum, because I want to preserve the perichondrium of 5 millimeter caudal septum. I will show why. I perichondrium. So with the retrograde dissection to the caudal septum, I dissect it, and then when I reach to the caudal septum, I turn other side. You see, it's all the perichondrium is preserved. Can you see my pointer? Right. Yes. This is the right side of the septum perichondrium. This is the left side of the perichondrium. I preserve the membranous septum for years, but some of patients had dropped with the time, with the aging, with the heavy skin. So that membranous tonguing groove is really working nice. I do millimeter or 5 millimeter membranous tonguing groove, not cartilage to cartilage. It's Eren Taştan's and the Nazem Cherkesh idea. I like it very much. I will show how to do that. I mark the midline. You see, this is the caudal midline. You see that mark. I incise with the scissors. I create a pocket, but I don't go through the medial crura. So this is only splitting. Think about medial crura Pitanga. That's all. If we create a simple pocket and we put the caudal septum inside, there is no cartilage to cartilage or suture here. Only we will close the mucosa. That's all. I will show how. Remove the excess mucosa. I do always enclose if there's excess mucosa. It's important because I don't do structure, so mucosa excess should be removed. I close the perichondrium of the septum because the mucosa will carry the tip. So I close the double layer or one layer, close the mucosa. So what's happening here? Think about the Pitangui ligament anatomy. You see, it's becoming thick at the supratip, as Yves Saban says, pass under the domes, superficial mass pass over the domes and join into the orbicularis oris. Deep Pitangui ligament pass under the domes and join to the medial crura and the foot place. By the foot place, it's joined to the depressors. But Daniel says there is a real connection to the depressors here. I think two depressors join into the foot place. So I think Pitangui ligament is finishing here. So with that membranous tongue groove, I separated only medial crura Pitangui ligament. Because of the caudal septum finish, or septum finish, so I didn't split it. Middle crura Pitangui. So it's creating a cushion effect. So we can say ligament, think about like this. That's the membranous tongue groove. So think about it's a body, okay? Two arms. Livy is lying on the caudal septum, okay? So it's the hip of the ligament is pushing the domes forward. Think about you open the legs and move a little bit and sit over the anterior septal angle, and that's the point. You see, with the moving the medial crural ligament over the caudal septum, so it's takes rid of power from the caudal septum, but you preserve here, so it's really gives good stability. Hello, my clay in my office. This will be distal Pitangui. We split the medial crura Pitangui, but not medial crura. You see, enclose. Then the mucosa. So we have a pocket. So middle crura Pitangui overlap or sit over the anterior septal angle. So when we close it, we have a good support. So I remove the excess mucosa and on basically I close the mucosa. In open approach, how to decrease the septal extension grafts or overlay on tip onlay grafts. Imagine we reach the septum and we separate the medial crura. If you suture the medial crura or middle crura soft tissue back, so you create a soft tissue under the domes. That's the point. Have a look. Double zoom. Already I suture before. So we finished tip surgery. Before I put in a strut, first I pressure the soft tissue between the medial crura. It's equalizing the tip cartilage. And I suture that soft tissue, and with the 5-4 PDS, if you go to the supratip, there's the Pitangui ligament anatomy. You see? You control the supratip with this, but also your tip cartilage jump over the anterior septal angle and sit over it. It's really good support.
Okay, so Baris, how different is this from what Bowman Guyron is doing?
He's removing that soft tissue, and he's passing his stitch from the dermis, and he's suturing the supratip soft tissue, supratip dermis to the anterior septal angle. I suture supratip smas, that's the Pitangui, to the medial crura soft tissue.
Understand.
There is no real connection. Nasal smas to the septal septum. Nasal smas is joined to the tip cartilage, not the septum.
Okay.
It's
quite a different way of thinking about it.
Yeah, it's only it's a static suture to the skin to the septum. This is dynamic. You suture the nasal smas to the tip cartilage.
Okay.
Enclose step by step. Okay, we dissect the septum. I go to the W point. Dorsal perichondrium start there. So the simple method for the dorsal subperichondrial dissection is to find the perichondrium on the W point. W point is the point where the upper lateral start. That's the cleft. So pointed scissors, Cherkesh scissor, with the opening legs, I found the perichondrium, go with the elevators. First, I dissect the upper laterals. That's sweeping action. I dissect retrograde or inferiorly and stop to scroll ligament. It's very hard connection. Finding the dorsal perichondrium is very difficult over the scroll or over the upper lateral crura. That's the easy way. Then I go to the dorsal tip. So this is the lateral crura preservation. That's the rim flap. I will show the dorsal the dissection again. When I rim incision, I want to talk about the rim flap. What is it?
Yes.
There is an article in the Surgery Journal. We classified the lateral crura in 4 types. Type 1, there is no excess on cephalically caudally. Type 2, there is only cephalic excess. So you can treat with the cephalic resection. That's okay. But type 3, there is only caudal excess. These patients are really dangerous. So the lateral crura is close to the nostril rim. So if you treat the lateral crura with cephalic resection, so you create a huge empty space here. So that lateral crura migrate upward and takes the rim back, and you can see notching. Type 4, basically you can put all the bulbous tip into the type 4. Cephalic excess, and in my experience, 60% I'm operating type 4 cases. So the rim flap, if you have caudal excess, do rim flap. Very easy, very simple technique. I'm trying to tell you what's the logic.
Okay.
Elevate the margin. If the cartilage is close to the nostril margin, okay, incise that caudal excess, forget it. That's all. Why I do this? Because that convex caudal excess doesn't create any highlight on the skin. So I'm using that unuseful, unnecessary caudal excess on the skin. My incision became the new caudal border and creating a highlight on the skin. And rim flap turns into the facet, shadows, and supports the facet. You see, where highlight, do your incision there.
Okay, that's interesting. Eh?
Okay? If this is type 4 case, caudal excess and cephalic excess. With this treatment, so 3 millimeter width with the rim flap. So instead of doing 8 millimeter cephalic resection, or you can do only 4 millimeter. So I don't do more than 4 or 5 millimeter. Generally 3 or 4 millimeter cephalic resection or flap is enough for me. If it is not concave, convex lateral crura, I do Özmen under oblique cut. So that's so it prevents the tip stitch pinching. Özmen sliding flap. Look, this lateral crura is wider than this. You see my mark? Already 3 millimeter. The caudal excess is on the skin. So I have rim flap. So I don't need to put rim grafts. It's symmetric. It's time consuming. So we use the center part also, not the caudal part. We use the center, most powerful of part of the lateral crura. Oblique cut, lateral dissection. It prevents preserved scroll because there is an anatomic connection between the upper lateral and the lateral crura. Horizontal scroll, vertical junction of the scroll ligament to the transversalis muscle. Suturing it, simple. And these two flaps rim flap and the Osman flap works with the lateral crural steel. I don't fight with the lateral crural. I find the proper lateral crural with the lateral crural steel.
So I want to ask you a question there.
Yes.
So I just to understand the sliding flap. So you've done like the cephalic trim, but that actually then comes back underneath where you've cut. You're not going to remove it and do something else with it. You actually kind of let it drop in underneath it, and then you suture it back on itself.
Yes, exactly. What you want to remove, don't remove it. Inside, make it flap, slide under. If it is very convex, turn under flap works better. I use both. Lateral crural preservation. Imagine this lateral crural. I take a photo after dissection. This lateral crural is wider than what you see. I marked my rim flap imagination here. You see, now it's on the skin. You see, this is the color. Because of this, only I need to treat 3-4 millimeter. I incise it obliquely, I slide under, and I pull the lateral crural. I find the proper lateral crural length, and this is my knee dome. Generally, we don't need this part, so I resect it. This modified lateral crural preservation. Emmanuel from France, my friend, is doing this, publish it also. Lateral crural preservation with lateral crural steel. This old dome, this is new dome. So let's see on the thin skin patient what we are trying to do. You see the scroll line. Scroll lines, where is your lateral crural is cephalic border. In bulbosity, if you have cephalic excess, scroll line is high. So you want to decrease bulbosity. Okay? Also think about rim, nostril rim, and go, and you're gonna see the caudal highlight. So this is also caudal excess, a good place for highlight. So I want it higher. You see the nostril lobule highlight is coming. Go like this. That's the drawing lesson. Discuss it with art teacher, not me. So they want to see highlight here, and they want to see a facet here, artist, and they draw on this painting and show on the sculpture. So what I do, I use this caudal excess as a rim flap. My incision is like that, so it's turned. You see, the highlight is going with my knee rim incision or transcartilaginous incision. This is turned into the facet. Now I have a bigger facet with rim flap. Scroll line is lowered a little bit. And still there's a connection between the lateral crural and the upper lateral. So lateral crural cannot migrate. Also, I suture the scroll ligament, so it's creating a barrier. Lateral crural cannot overlap lateral crural. So I don't want overlap. Side to side is nice. Have a look. This is a very good example for caudal excess. You see the scroll line is not high. We have 2-3 millimeter caudal cephalic excess here. Most of the lateral crural excess is caudally. I'm trying to show the surface analysis. You see the oblique weave is amazing to show it. So that surface analysis, I surprised a lot. I always try to see the nose anatomy before opening it. You know what we say before the surgery. Let's start skin and see the cartilage, see the problem, and treat it. No, we can see the problem before open the skin. Here we have a loss of caudal excess. I use the caudal excess of lateral crural to support my facet and became new highlight. So the scroll line lowered a little bit to 3-4 millimeter. You see the bulbosity basically transferring the mass facets to the shadows facets. You see highlight? There is no shadows. So you change the balance of the highlight and the shadows. If you have bigger shadows, so tip became defined. Okay, think about you. We are surgeons, okay? We read lots of mathematics. We don't have lots of art education. We only focus to cartilage. So cartilages are big and narrow it. But think about the shadows. Increase the size of shadows, so you treat the bulbosity. So that's the transverse thing. We transfer to the highlights to the shadows here. And the lobule, I want to say this. I will talk about compartment. Dorsal is preserved also here. That's bulbosity. So this turning into the facet, bigger facet. You see the middle crura very clear. Another one. This is dorsal preservation. One supratip no onlay graft. We increase the lobule projection with lateral crural. Oblique we've shown. You see the caudal excess, scroll line. You see is lowered a little bit. If I need to need rotation, I don't supply the rotation with only the lateral cephalic resection. I only touch to the upper lateral caudales. I shorten the upper laterals, so I transfer the scroll higher. So don't think only the tool for the rotation is lateral crural resection. No, it's so dangerous. Generally, we don't need more than 2-3 millimeters. 3 millimeters. I live in Turkey. We have lots of big noses, so even the Turkish nose can treat 3-4 millimeter cephalic treatment. That's we use generally Osman flap. So that's the facet polygon, and this is the infralobule polygon.
A quick question in terms of
yes.
the sliding flap. Do you actually have to then on the inside create a pocket for that to be able to slide in?
Yes, we have to do that.
Really, if you don't make the pocket, it's going to actually narrow the internal nasal valve area.
You're right. First, I do oblique. Even in the article, Özman says that he dissects the mucosa with the rotation movement with the scissor. So I incise and I elevate. I try to dissect subperichondrially. Even that dissection decreases the bulbosity. That's important. We need a pocket at least width of the sliding flap. Maybe 20-30% bigger pocket can be better. This is medial crura dissection, subperichondrial. That's the scroll window. In open approach, maybe you don't need to do that. Probably we are doing research to the same place, but that's my approach to the dorsum because I don't work to the midline. I work from the laterals. So window to reach the dorsum. I open the upper lateral superichondrial plane. As you remember, I already dissected the upper lateral perichondrium over the W point, right? Mm-hmm. Now I dissect the lateral crura subperichondrial. So with the pushing the lateral crura scroll window opens, I reach upper lateral subperichondrial plane, then I go to the bone. So the exposure is really nice with the crural retractor. So that's subperiosteal dissection. So the fifth key point is opening a window between the superficial smas and the deep smas. We will preserve the pitangi now. With the horizontal movement, blunt dissection, from the left side 2-3 millimeters and then right side 2-3 millimeters to not create different. So we preserve the pitangi ligaments very clearly. There's a window here, so we can pull the cartilage from here. And we can see vessels. So how much dissection we need? Years I did limited dissection, so I had over definition problems. I inject fillers to the supratip. So I play with this. Look at that drawing. That's the lobule projection. So here in this case, I'm increasing projection. Think about this, the compartment, lobule compartment created by the pitangi and the scroll ligament. So if you increase the lobule compartment, I mean lateral crural, onlay grafts, we have to enlarge the infralobule lobule compartment. So what I do, another home message, where is the ideal supratip breakpoint? My art teacher says it's between the keystone and the tip. So dissection should go on until your new supratip breakpoint. So generally, I have short lobule cases, so I have to dissect more to enlarge the lobule compartment. So here I dissected. So without intercartilage incision, we can easily deliver the tip cartilage. We can finish the tip surgery while the pitang is intact. That's the end point. So it shows the supratip breakpoint. We can put your scissors and you can go to the supratip. You can mark it. That's your new supratip. If your supratip breakpoint is close to the tip, so you dissect more. So with incremental dissection to this packet, you can find your supratip point. That's the scroll window for dorsum surgery. At the end, you see that's the upper lateral perichondrium. Sometimes horizontal scrolls stays on the SMAS, and I suture that cartilage to the mucosa. But sometimes I saw that cartilage in internal examination. Well, I like more to suture in the upper lateral perichondrium to the upper lateral again. It's powerful. So it's sliding. I like to do suture the same place. Perichondrium to the cartilage again. Think about this perichondrium, this scroll, suture back. So you space, the lateral crura cannot go upward. It increased rim support, rim closing the dead space, or I say it's scroll reinsertion.
What suture material are you using for that?
5-4 PDS. See, this is the rim flap incision. I will show the steps with the videos. I start from the dome. Dome should be cartilaginous. The ideal rim flap incision is 2 millimeter width and 5-6 millimeter length. Third, for the dissection, key point is the turning point. It's very difficult to find the perichondrium here or at the dome. Turning point is thicker, so we can find him here. But this dissection is indicated for thin skin, strong cartilage. And you don't want loss of red ray. If you want more red ray, do subsumas. Yes, go on.
At that turning point, sometimes in that area, there always seems to be a little artery that bleeds. But you're not underneath that because you...
There's artery lateral to the turning point, because I know also I'm releasing the lateral crural caudal perichondrium. It always bleeds. I know that.
It drives me nuts. It's all nice and clean, and then suddenly, poof, it starts.
Yes. I think there's a marginal artery following the lateral crural caudal margin. So have a look, Pitangi preservation. With the scissor, okay, I cut the perichondrium a little bit. If it is very thin skin, even I want to preserve the perichondrium. It's making a camouflage for the tip cartilage. You can do it with the subsmass dissection. If you have weak cartilage, okay, tip surgery becomes really difficult. So if you see weak cartilage, in Latin America, there's lots of weak cartilage. I think subsmass dissection is better tool. Again, showing the scroll reinsertion, upper lateral caudally. I go to the upper lateral perichondrium. It's like closing a scarpa fascia. So you create a lobule compartment again. So let me go back. As you remember, I said, what I see in the surgery, I don't see that after 1 year. But that's very difficult thing. So in archery, you throw your arc a little bit high because it's going down. So it needs lots of experience. What I want, my aim is what I see in the surgery, heal fast and stay like that. That ligaments improves a lot. So, I was doing because of the projection loss, rotation loss. I was doing over projection, over definition, so I left that. Nowadays, I don't do over projection, over definition, over correction. I left like this, generally stay like that because of the ligaments. So, yes, go on.
In terms of the question here, it's very there's not much bleeding that's doing when you're operating here. The question I have here is it because of the planes that you're dissecting in, or also the amount of local that you possibly using beforehand?
The joke can be, I took hundreds videos and this is the less bleeding one. No, generally bleeds less. Let me say why. First, I was working only with one anesthesia doctors. So also his chapter is in the preservation rhinoplasty book. He is choosing specific agents for the anesthesia. We wait until the patient blood pressure goes under the 90. And injection is so important. I inject to the nose 3 cc on the tree, and the concentration is 1 to 40,000. It's a little high. But into the septum, I inject only 2 cc, and because septum works like intravenous injection, so I inject only 2 cc, but it's 1 to 400,000 to really dilute it. Inject more doesn't mean bloodless surgery. So injecting 3 cc to the nose is okay, but the septum injection, we have to be very careful. I inject the septum only for decreasing pain, not for adrenaline effect. So what is important? Patient use xylocaine, pseudoephedrine, or before the surgery. When the patient hospital use Otrivin. So it's decreased absorption of your local anesthetic, and also they give steroids before the surgery. It's really decreasing swelling in the surgery. Yes, and the dissection plane, subperichondrial dissection doesn't bleed. Only my incision is bleeding here. Subsumous dissection, bleed more. Or if you dissect the muscle, or if you resect the muscle, loss of bleeding because the vessels are there. So everything is important. Waiting, slowly injection, and injection point, local. I use mepivacaine, not lidocaine. Mepivacaine is safer than the bupivacaine. I prepare fresh with adrenaline. That's the small tricks for bloodless surgery. Let me come back to this. Look, already there is soft tissue. In open approach, we separate that, right? So if you suture that, so you construct the middle crural. In this point, I had a pocket for membrane septum. Okay, it's 3-4 millimeter behind. There's a pocket for caudal septum, but this is the middle crural is intact over the anterior septal angle into the supratip. You see this we see the distal pitang is going on under the skin and joined to the supratip muscle. Now, have a look. I think the soft tissue between domes. It's like mimicking the interdomal ligament. Now, think about I put some soft tissue cushion over pitang ligament. It gives projection. If I don't want to projection a lot, local projection, I don't put that soft tissue suture. Okay. If I want to preserve the projection, I put that soft tissue suture. That's important. Generally, I suture, but in over projected cases, I don't suture it. So this is the figure of 8 stitch to equalize the domes. This is what I do in open surgery. This is open tip surgery. I don't do any rhinoplasty without seeing domes. Always, I did 2 or 3 cases, which, as Joseph approach, not seeing the tip. So I promised myself, always I have to see the domes. Even the necessity, we need 1-2 millimeter steel. That's the tip surgery. My point is to ligament here. So I did medial crural overlap here, as you see. I want to show how was the tip surgery is possible in close with the ligament preservation. I preserve the empty spaces between the interdermal space. Interdermal space should be 100 degree C point. I pass deep from the medial crura with the strut, but when I'm coming back, I don't pass from the strut. So it's creating polymellar polygon and infraglobal polygon. When I squeeze it, have a look. So columella and coming, and you see the middle crura divergence, so we create a C point. That's the tie stitch. This case for a dorsal preservation and the tip ligament preservation, supratip control. Now that's the lecture. We spent a lot of time. I have time to answer questions. I hope. I know I ligament preservation only one point, but that's the point to understandable.
No, it's you can close that window there. You're sharing.
Yeah.
You know what stands out to me is all the pictures of the ladies afterwards. They got these big happy smiles because they're happy with their results. It's fantastic. Wow. Yeah, there's so much to think of. My first comment is I'm just happy that that technical school that you started at ended up that you got accepted for medicine, and then that you didn't end up doing so much hand surgery, but you changed to rhinoplasty, because it's helped so many of us because of that. So I'm very happy for however that happened. So, okay, so this is the question. The most important thing I would want to ask you is, I think the majority of the listeners on the podcast are still open structural rhinoplasty surgeons. So what advice would you want to give to people who are still in that kind of frame of mind? I've had an interesting comment come in to say, but why do you want to change something if this thing's working? And then I listen to a guy like Dean Tuyomi, who's been in the game for more than 30 years, and he's even changing. So perhaps some comments in terms of somebody who is stuck in doing structural open rhinoplasty, and especially in the light of what we've been speaking about, the ligaments tonight.
All right. You know, we are surgeons. Yeah, so we have egos. So that egos are oil. So we have to use, so that push us to think more, focus. So that ego push us to be a little fanatic. So I became fanatic. I confessed. I want to confess. I want to do everybody dorsal preservation. No, it doesn't work. Focus on the ligament preservation to everybody. Subperichondrial dissection was my rule. I did everyone. No, it's not working like this. So I'm changing. So I'm trying to put the indication for my young colleagues. So I repeated a lot in this broadcast. For weak cartilage, do subsumas like this. So if you don't want red rape a lot on dorsum, do subperichondrial. If you want red rape on the tip, do subsumas. If you don't want red rape, already you have your patient's tip cartilage very visible, do subperichondrial, works really nice. So the message, learning techniques, learning surgery is difficult. If your practice is not on rhinoplasty, doing one in a week, don't change your technique, because the best technique is what you have the best result. So changing your technique, you lose time. Also, it's not fair. Your patient. I remember I turned to the close in 10 years was so difficult for me for 6 months. Some figure out all the problems. But if your main practice is, why not? There's really the deformity is amazing. Even the Rolling and deformity, they really carefully, all the young guys, and they use it. Okay, even the Roland Daniel put me that my subperichondrial dissection into the thick skin patients. For the thick skin patient, he was believing in deformity. But we saw the Pitangi works for red for thick skin also. So if you do the rhinoplasty, I think now the level is going high. So we the structure and the preservation nowadays. Say this is Yves Saban saying, worst indication for the structure for preservation. Let me give you an example. If you have beautiful dorsal, but perfect axis deviation and no hump, it is very difficult to structure because you make the bone septum perpendicular like other bone and you move. As Charles says, book osteotomies, you move the one bone to other bone. One, the septum is midline, the other bone is shorter. So you have to put the asymmetric grafts. And my friend, that surgery always finished with camouflage. You can't achieve it. So it is very easy with dorsal preservation. You mobilize, you bring to the midline, no camouflage. Or very little camouflage, you finish your dorsum surgery. Why not? But if you expect 1 year of Rhinoplasty in a week, yes, don't do dorsal preservation because you can achieve disasters. Because even though it takes years, you learning the structural rhinoplasty, it takes years. Putting a symmetric septal extension graft is not easy. Doing, why I'm not doing lateral crural transposition, because I can't. It's so difficult. I achieve asymmetries. Doing it symmetric, okay, it needs you hands. Hand skill. The Intorimi can do it amazing. It's very difficult. So, yeah, doing to everyone to the lateral position, rim flap, Osman flap, or turn under, and with the lateral cross still. Yeah, so tip surgery can be more easy. If you need augmentation, yeah, septal extension is very important, and the tip cartilage you have to put every graft very symmetric way. But why at least we don't preserve the ligament, Pitangi ligament, and put a small graft, not a huge septal extension graft? So the patient's septum stays inside. So it's very important to do the revision to not go to the rib. So if you do your patient a revision, so you go rip your patient, it's very difficult to say your patient. I will go to the rip or your revision now.
Exactly. Well, you've actually answered. It's been quite nice testing our podcast through YouTube because quite a few questions have come in, but I think you've answered one of the questions about septal extension grafts and columella strut. A question from South America is, do you recommend sub-smash dissection in the tip and subperichondrial in the dorsum?
Right.
Okay. Well, there we've got it. Thank you for that.
Because you have less hump and a weak tip cartilage, but also thick, very thick Pitangi ligament. So if you put Pitangi ligament, okay, you put less onlay graft. But the dorsum, little hump, you don't need a loss of red rape, but you need camouflage. You know the very of the dorsal perichondrium, it's keystone. You know, our most of the irregularities at the keystone because we remove the dorsal perichondrium with the hump if you do subsmash dissection. But dorsal perichondrium on the dorsum, okay, it works for you. It's 1-2 millimeter.
Wow.
Natural, beautiful camouflage material. And we know subperichondrial dissection makes the perichondrium thicker because the contraplast increase the perichondrium layer. That's very good camouflage material. Also, I see any the skin sometimes attached to the bone. You lose that flexibility of the dorsum.
Yes. Yeah.
Perichondrial dissection, you don't lose that. So your skin is still more. Hypodermis is attaching to the bone because of the blunt dissection. Spraying blunt dissection with the scissors is you don't dissect only. You also transversalis muscles, auricular dissect, and the muscles comes to the here.
Okay.
Long talk. Rhinoplasty never finish.
No, it never finishes. I've got one more question here. The
Yes,
question is, in the case of very thick skin, do you add a tip onlay graft to this technique?
Yes, sure. I do. One of my 10 cases is I put a lot of shield, pack graft. In primary, is 10 around 10%. Lateral crural still decrease the onlay graft a lot, but because in Latin America, in South America, middle crural is short, medial crural and lateral crural is short, so tip stitch doesn't enough. Lateral crural still you can't do more than 1-2 millimeters. Onlay graft, we have to put onlay grafts. In Turkey, it's very rare.
Well, awesome. I'm going to get you guys now to
Maybe
because we're going to carry on talking here forever, but I've got to make a call on this. I'm trying to quickly get the. Wait, let me ask this last question whilst I get the contact details for the Come guys. So here's a question from Cape Town in South Africa. If you have cephalically orientated lateral crural, you mentioned you do not reposition the lateral crural. Do you do lateral crural onlay or strut grafts in these cases?
Maybe I have to show if I can find transpose. I can show it.
Yeah, please do.
Wait.
Okay, so whilst you find that, I'm going to just read out the email address that the people can contact if they're looking for a good discount on the Comeg machine. So the email is richard.maloney@maloney-medtech.com. I'll spell that out for you. So it's RICHARD.MOLONEY@MOLONEY-medtech. It's MEDTECH.com. So please get hold of Richard Maloney if you want to get a good deal on a piezo from Comeg. So Baris, you managed to find that little...
Yes, I find it.
Okay, great.
Share, right? How can I share?
Yep.
Screen, right.
Yes, there we go.
Let me show some marks. That's the supraalar groove. That's the turning point. And that circle, we use it for nose drawings. This is a nostril lobule. How I put the cephalic malposition diagnosis, not on the front, because everybody is using different lights. On the side, this is the tip lobule, you see, very small. And this is the nostril lobule, very big. So this is cephalic malposition for me, real cephalic malposition. So not all the bulbous tip are cephalic malposition. So what I do, lateral crural, I really, it's very difficult for me. Okay, the problem is the bulbosity here because that big nostril lobe is lateral crura upward. So malposition. And I think that lateral crura malposition is the disease of the lateral crura, not here. The problem of the lateral crura, medial to the turning point, is generally the wetness, convexity, and the long lateral crura. So we can treat the tip surgery, but I can't treat the tail with the lateral crura tip surgery. So what I do, so lateral crura, even bulbous tips have caudal access, and there is no cartilage here in the nostril lobule. We know from the tail ring concept. So what I do, I go not infracartilage incision. After the turning point, I do straight mucosa incision, and I dissect everything, especially. In this case, generally that case have hanging ala because of the big nostril lobule. When I resect the hairy skin, because I did lower than the inframarginal incision, my incision was straight into the mucosal skin. When I suture to that mucosa of the lateral crura tail, so that we can elevate this part to upward. So the lateral crura, that dimple decrease. That's the lateral crura transposition. So when you treat that deep supralar groove, so lateral crura, cephalic malposition look decrease. You see the lateral crura is creating a dimple here, deep supralar groove. So I remove soft tissue. That's my approach.
That is beautiful. I'm going to do that tomorrow.
Okay. You have huge lateral crura, nostril lobule, right? Hanging ala?
Yeah, so we have such a mixed bag of rhinoplasties in South Africa.
Right.
But that's just such a different technique to like dissecting free the lateral crura and doing a turnover or turn under flap and repositioning it.
But I want to show this is bulbous but not cephalic malposition. You see the lateral crura is going and showing the medial canthus. But I think this is the long, wide, convex lateral crura. You see on the side, nostril lobule is very small. So tip surgery works. Another point, don't think about changing the finishing point. All the droppy points or long lateral crura looks like cephalic position, cephalic malposition. When I change the starting point, okay, also I change the direction of the lateral crura. You see, after the rotation and then releasing the lateral crura, we change the end of the direction. But with this still, I change the starting point. You see, when you change the starting point, it shows the lateral canthus. And with the ring flap, with the convexity, okay, this case is not real cephalic malposition because of the small nostril lobule. So the tip surgery figure out this. But this is cephalic malposition. You see the huge nostril lobule here? So if we treat that lateral supratip fullness, okay, we can decrease the really with the lateral crura still, and with the dome fixing the lateral crura resting angle, oblique dome stitch like Dean Torimi shows. This can decrease with the resections. This is not cephalic malposition. Tip surgery figure outs. This is cephalic malposition. This is real cephalic malposition. No cephalic malposition on the tip bulbosity. Tip bulbosity. If I have hanging, I do directly resection from the caudal. So if you treat the hanging ala, also you treat the cephalic malposition. See that hanging ala? I resect directly from here. This is tail transposition. Yeah. I hope you are not sleeping.
No. Listen,
I like
Barish,
to talk.
listen. We've been going for an hour and
Yeah.
40 minutes. We got to cut this now. Our
Yeah.
listeners are not going to go to work. They just want to listen to Rhinoplasty the whole time, man. So honestly, man, I thank you
Yeah.
so much. On behalf of the people from more than 70 countries, we've had like nearly, we're coming on to 20,000 downloads of this Rhinoplasty podcast.
Yeah.
Thank you very much for tonight. But thank you for the work that you guys are doing. Thank you for the congresses you guys are putting together. On behalf of the people from around the world, thank you. We really appreciate what you guys are doing.
Yeah, Cameron, we want to see you in Istanbul. I hope Corona gonna finish and we can do the structure preservation meeting again in Istanbul.
Yeah, no, I'm
Let's
going to
see.
come.
Keep in
COVID must
touch.
go away because it's too late. I want to come and see you and see
Right.
Goxel. I want to see you guys, man.
All right. Thank you very much for inviting me. And
Great.
thank you very much for watching.
And to all the listeners, thank you for this test that we did to live stream it at the same time on YouTube. We hope it worked, and we'll be actually doing the proper release on Sunday of this podcast. So thank you very much for listening, and we'll see you guys again next week.
All right. See you. Bye-bye.
Thanks, Baris. Okay, awesome. Good night, eh?